Hi, my dear parents. Welcome to Growing Right, a podcast by Ankura Group of Hospitals, where we are trying to deliberate into specialized pediatric care and its role in improving children's health, how it plays a role in children's health on a day to day basis. So, it is always a challenge because now pediatrics is more diversified. It is not only about fevers, vaccinations, there's a lot more associated with pediatrics. So, as a part of it, we have a group of specialized people in pediatrics, people who have specialized, subspecialized in pediatrics, like different fields of pediatrics, who are with us at associated with Ankura, who will be coming to this podcast and giving their insights on regarding children's health and what else we can do and what to do and what not to do. So I am Dr. Suman, consultant pediatrician, senior consultant here at Ankura Hospital, and I've been practicing for the last 20 years. And my interest is general pediatrics, pediatric allergy, pediatric asthma, pediatric nutrition, and growth disorders in children. Today, I have with me one of the most charming and one of the most friendly, child-friendly, parent-friendly pediatric endocrinologist with me, Dr. Mounika. Welcome, Dr. Mounika, to the podcast.
Thank you so much, Dr. Suman, sir.
It's-
I'm really excited and I'm eagerly looking forward to share my insights.
The moment the thyroid disorder is diagnosed,
Yeah,
because of the
yeah,
height, see, normally the first thing to catch is very glaring is the height.
Yes.
The height is not matching up to the age.
correct.
Then we look at the bone age of the child,
Correct,
right?
correct,
Whether the
yes.
bones are growing
Bone,
well or
yeah,
not, we get
yeah,
an
yeah,
X-ray done.
correct.
Bone age is also low, the height is not growing. So my point to the parents normally what I
Yeah,
would say is, if your child's clothes are not shortening
Yes.
every year on year,
Yeah,
be
yeah.
concerned, visit the pediatrician.
Yes,
If
definitely.
they have to shorten,
Yeah.
understood,
Yeah,
the child's
correct,
cloth should shorten
Should shorten.
at any stage, at every year. If it is not
Yes.
happening for 1 to 2 years in a row, there is a problem. Please
There's a
visit your pediatrician.
problem.
Very easy to
Yes,
pick up.
yes,
Other than
sir.
that, because they can't
Yeah,
remember
yeah.
all the heights,
Remember,
growth
sir.
charts, and all.
Yes.
And have a yearly checkup. It's always better.
Always good.
Sir, everything is good or not? Because for first 1 to 2 years, vaccinations will run the roost.
Yeah,
Will not have
yeah.
much of issues,
Correct,
but it is
correct.
then you
Then
miss it.
later, sir. Yeah.
Miss it. So my question would be, once the thyroid is diagnosed, you get
Yes.
certain levels.
Yes.
Right?
Yes.
There can be like the level of 5, 5.5 is normal in
Correct.
most of the reports.
Yes.
Right? You get a value of 6 and 7.
Right.
Recently,
right.
parents are really concerned.
Yeah,
I see
yeah.
parents crying and
Crying
showing, sir, does
also,
my child have a
yeah.
thyroid? 6, 7, 8. That's
Correct,
all the value comes. I think I've referred a few
Yes,
cases
yes.
because I feel
Yeah.
that's an opinion.
Correct.
Because
correct.
we don't start medication
Yes,
for them.
yes,
We always take an
yes,
opinion. So what
yes.
is your approach?
Correct.
If a child's level is more, when will you actually start medication?
Start
Bottom line.
medicating.
The moment the
Right,
thyroid level, T3, T4, TSH. This is what we normally
yes,
do.
Yes.
You see it high, you immediately start medicine, so you do
Yeah.
something else.
Right. So if the child comes to us, like sir, the same case that you had referred, I think his TSH was somewhere sitting at 6, and his T3 and T4 levels were normal. And clinically also the child did not have any issues. I think it was, part of some weight gaining issues or something. I think the screening of the thyroid functions were done. So in this case, we don't jump into treatment immediately,
Okay.
because there are other factors. What we would like to see
Mm.
is like what might be the probable cause of this elevated TSH. So we do commonly see in obese children.
Okay.
Obesity
So means
itself.
his thyroid is not really a problem there. It is
Yes.
just because of the obesity the TSH level would
yes,
be high. Okay.
because of the obesity, the TSH level rises.
Okay.
And once this child follows a healthy diet and he starts losing weight,
So it
in
comes
another-
down.
Yes, it comes
Oh,
back
that's
to normal.
interesting.
And what happens is, like, sometimes the parents get confused because they might have received opinion that your child needs to start treatment here, and
That's
then
because he
they
has
come back
obesity. He has
crying.
obesity and the TSH level is
yes,
also
yes,
high. It's
yes,
okay.
right. And in which cases do we start treatment with a TSH of 6 is if there is a strong family history of hypothyroidism in the
Okay, it comes from genetics also.
so
Hypothyroidism.
genetics can give a predisposition.
Hmm.
It's not that if the parent is having hypothyroidism, the child has to get. It's
Hmm.
not compulsory. But then, like, if
It only happens from the newborn, na? Congenital hypothyroidism.
congenital
or what. Otherwise,
even autoimmunity also, sir. Like autoimmune
So it's
hypothyroidism
genetic.
also.
It's hereditary.
Yeah, hereditary. Like
Okay.
if one of the parent has any autoimmune hypothyroidism levels are normal, then probably it's a very small dose that we start.
Okay, that's all.
Yeah,
One
that's all.
small
Yeah,
dose and
yeah,
that's enough. And
that's
how do you monitor him, follow up again after that? Because the concern, next concern is, it's a shocker for parents, I'll give you. First thing is thyroid is a big shocker for them.
Correct.
Then it's good thing you told me that not every elevated level of TSH we
Needs
should diagnose it
treatment.
as hypothyroidism.
Correct,
There's a thing
correct.
called subacute hypothyroidism.
Subclinical
Hypothyroidism, where obesity or other issues,
can cause,
autoimmune issues also can elevate it. And
Yes,
working on the lifestyle can decrease it.
Correct.
So always
Yes.
better take an endocrine opinion.
Yeah.
I always have a second opinion
Second opinion
before
yes,
you go for
yes,
it. I
correct,
totally understand
correct.
it. Now the second shock.
Yeah.
Once the thyroid tablet is given,
Yeah.
can we stop it?
Right. So if it is autoimmune hypothyroidism, then most likely we won't be able to stop it because, I mean, even practically we have seen, like, when at subclinical stage, like when the TSH was at 5 or 6, and the child had presented with a goiter with positive anti-thyroperoxidase antibodies, and the treatment was advised, but the parents felt like, okay, like, let us not, like, start it now. But they came back again after 3 to 4 months time when the TSH like elevated to more than 10. So in autoimmune hypothyroidism, it's going to progress.
Okay.
So if the autoimmune antibodies are positive, then most likely chances we may not be able to stop the thyroxine ever. But if the autoimmune antibodies are negative, then probably the thyroid functions itself are going to speak for themselves.
Mm-hmm.
So if probably the child is on a very minimal dose, 12.5 or 25, and if his TSH is in the normal range, then we won't be able to stop it. But if the TSH is suppressed, it's coming like below 0.5.
Okay.
And then we can taper and we can see.
Okay. So my question would be, so autoimmune is lifelong.
Yes, autoimmune
we cannot
is
stop
lifelong.
it. It keeps antibodies keep coming on. There's no
Yes.
way we can neutralize it. No way
Yes,
we can
yes,
stop it.
yes.
Right.
There is no treatment
No
to
treatment.
treat the antibodies. per
Antibodies,
se.
right.
Correct.
So normal acquired hypothyroidism, otherwise, based on their TSH level, you'll take a call.
Yes.
Right.
Yes,
If it is going
yes.
below, then he's on minimum medication, you can take a call. So there's something positive and hope for the patient,
Correct.
both the ways.
Yes, yes.
Because height is a concern.
Correct.
So few parents, because the concern again starts.
Yeah.
Right? They read a lot on social media. So mine is now asking as a parent, not as a doctor, because it's an information which is, there are a lot of things which I've gone through. You can just update me, like, doing yoga, eating only vegetarian, completely turning vegan. Right. Say that inflammation decreases in the body, that decreases the antibodies. So the autoimmune responses go down. So we outgrow thyroid without any medication. Lifestyle modifications, as I've rightly said. Hydrotherapy, drinking lots of water. That also helps in maintaining hypothyroid levels. So there are a lot of things, people work on, because parents work on, thinking that, this is something where I have to stop my child from taking a thyroid tablet.
The medication.
So your views, general views on it, because this question I'm asking as a parent. Hydrotherapy, vegan, turning vegan, understood? Lifestyle modifications, doing yoga, decreasing the stress responses. Does it play an impact as far as your management of hypothyroidism concerned?
Right. So all these factors may help in probably promoting the thyroid health, but they are not a replacement for the medication.
Okay.
Right. And definitely, like, I mean, I don't want to undermine yoga or like even the healthy lifestyle choices, but turning vegan, I would say, because there are no scientific studies established to say that turning vegan could treat the thyroid problems. So I think because out there in the Google, there is lot of
information, because I'll tell you where it comes from. They say that, eat a non-vegetarian diet, it causes a lot of inflammation in the body. It causes a lot of antibodies. That itself will be hitting our thyroid. This is where it comes from. They say you reduce that, automatically your inflammation goes down.
Correct.
So I get your bottom line.
Scientifically, like, there is no proven.
So what your point is, by doing all this is good for the child, because overall health will become better. Definitely will become more smarter, and his probability of increasing medication for thyroid might be very, very less. He might be on a very minimum medication for a longer duration of time, which itself is a good thing. So all these things are good. Drinking good water is good. Doing yoga is good. Having a stress-free life is extremely good. So
important.
the probability of this person having future problems,
see, that will be lessened.
The concern here for me is the thyroid, if it is not managed well in a child or in any age, will also lead to diabetes, will also lead to hypertension, will also lead to other problems, because every hormone has a connection with another gland.
Hormones.
So if we manage our lifestyle, discipline our lifestyle, the probability of us getting it automatically goes down.
Reduces.
So you'll become actually more smarter, stronger, and leaner. Right. So that is a probability, because you're adding a good thing to your life. So sometimes you become really better compared to what you were.
Correct.
I think that is something I got it as far as a thyroid disorder is concerned. So there's nothing called stopping medication.
Yes.
So it's really wonderful to have these because discussions going on. I'll ask one last question, then we will get on to rapid fire. One last question is the growing pains.
Right.
See, parents have an issue. My child is not growing, first point. Next issue is my child is crying every day night. With leg pains.
Correct.
Right? The child is crying every day night with leg pains. He's kicking his legs. He's crying. We have to press his legs every day. What is your thought process about it?
Correct. So, because I would say that, growing pains are pretty common in children, and especially after having like periods of physical activity, especially in the nights, they come with a bit of cramping kind of pain. Vitamin D deficiency is quite common, what I see. Like almost every child that that we test for has like low vitamin D levels. So first, like I feel that, growing pains, like let's first correct the vitamin D deficiency and check his calcium requirement. Like if he's like having good amount of calcium from his diet, well and good. Otherwise, like probably may have to use supplements during the period of the vitamin D deficiency. And if these two parameters are corrected and like still the child continues to have these pains, then the next thing would be like maintaining a good hydration. And probably I would say, like, in after this intense physical activity, probably like, some stretching activities or massaging would be more helpful. And I think
so ultimately is vitamin D has to be looked into. Sources of vitamin D. So major source according to me is the sunlight. So ensure that the child is outdoors.
Correct.
At least for 15 to 30 minutes. Timing would be 9 to 3. That's what I would advise. There's something small as a kid. I will just add it. I'm sorry I'm adding into you. Because in my grandfather, who is a veterinary doctor though, he was very interested in our natural. He used to give us these cod liver oil capsules. Which is another rich source of vitamin D. So a lot of other things just to add to the data. So that is something which actually helps. So you need to figure out what are the diets which help you out. Sunlight is a natural source, free of cost. You don't need to purchase anything with it. That is something which we can get in. So let's add on to it, because I believe after you coming in and associating with me, it actually helped us in identifying a lot of clinical cases, difficult cases. I had recently sent you a case where the child was actually looking like a 2.5, 3. I assumed he was 2.5, 3, and I was surprised that he was almost 5.5, 6 years of age. I think I've sent it to you, and I think you can just go forward, because that's a shocker. Because the child, poor guy, was looking too small. I immediately asked him, is it 2.5, 3? Parents said, no sir, he is in second standard. He's 6th class. I mean 6 years old. Immediately I said, no, he needs a visit. Immediately sent to you. You can just tell me, how did the child progress?
So the parents came to me that day, and I asked, like, how the child has been growing, and especially like they gave this, when I asked them, like, is he outgrowing his clothes? And they said, no, the same clothes that like what he has been wearing as a 1-year-old have been still fitting him or so.
Surprising, right?
So that itself was suggesting that he was not growing in between. And again I asked, like, didn't you realize that your child is not growing compared to other kids? Because he was clearly looking as a 3-year-old kid when his other friends might have been a little taller. So they said,
same thing happened with me also, right?
Yes. So they said, like, probably because one of the parents or the relatives was short in the initial years, so they wanted to wait it out whether he would grow. But then very good that the timely referral came that we could actually do a growth hormone stimulation test in the child, and he actually turned out to be a growth hormone deficiency kid. And we had to, and the parents were like very anxious about the diagnosis and like what is the further treatment. So when we counseled them about growth hormone injections, they had the reservations, like, about injections being given every day. And then a lot of counseling happened. And then finally they started on the injections, and the child is doing quite good.
So when is growth hormone deficiency is something, picking up at the right age is also something.
That's very important.
So when is the earliest? I think it's very difficult. Every year you monitor growth.
Correct.
When is the age when we feel that after that there is no point?
Yeah, that's important.
What age
Yes,
do you think?
yes.
Because the bones fuse. Can you tell us,
Fuse,
elaborate at
correct,
what age
correct,
is the thing
correct.
where we can't do anything more?
Anything, right. So usually, yeah, because many times, like even 18 or 20-year-old kids come and they say that, we want to take growth
Growth
hormone.
hormone, yeah.
And then I have
Everybody
to,
wants to grow taller.
yeah, everybody wants to grow taller, irrespective of whichever age
Age
they
it is.
are. And then, we have to explain them that, usually by 14 or 15 years of age, the growth plates are like 99.9% fused.
So anything we want to
Yes.
act, it should be before
Before
12 to 14 years
yes,
of age.
yes,
I
before
want it.
12 to 14
The
years
child
of
is not
age.
growing well, please
Yes.
ensure that you visit your pediatrician on
Correct,
regular
correct.
basis, check for his height,
Yes.
clothes are not becoming short,
yeah,
have a concern,
yes.
and get himself checked for any
Correct.
growth hormone
Yes,
problems.
yes,
And
yes.
earlier,
Is
the
the better.
better.
Yeah,
That's the bottom line, something
yeah,
which
yeah.
we should be really
Correct,
concerned about.
correct.
I
Yes,
think you have
yes.
hit nails on most of the things which pediatricians or people would be concerned about on a day-to-day basis. Coming to it, what else do you think you are being a part of Ankura right now?
Yeah.
What is that your wing, like endocrinology wing, is doing exciting things in Ankura, which will create a difference as far as the child's growth issues or hormonal issues or endocrine issues are concerned.
Correct. So, Ankura, it's been a brilliant experience at Ankura because, here we have all the advanced and latest technology available. Like, for example, for this endocrine special testing protocols, what we carry out, all we do at Ankura, especially like this growth hormone stimulation test, we do. And for example, in the field of diabetes, now like insulin pumps and continuous glucose monitoring sensors. So we have children who are using them and they're doing wonderful. So I would say in the technology part, we have all the advanced tech department, and also Ankura being a pediatric hospital. So, many parents themselves have come and told me this thing, the difference they feel in a pediatric hospital versus another hospital, that, they feel here that amount of empathy and the special care, because almost every personnel here are trained to provide care to a child and the family. So I think that makes a big difference, being a pediatric hospital. And also we have a wonderful a a multifaceted team here, because we have all the pediatric subspecialists available. For example, in obesity, sometimes we do see as a comorbidity of obesity, we have fatty liver, which is reversible if the weight loss happens in the first few years. So I would like to take help of my pediatric gastroenterologist, my colleague. So we have him. And for bone problems, we have pediatric orthopedic surgeons. So we have
and you also have a nutritionist.
Nutritionist, pediatric dietitian. Then we have pediatric psychologist, psychiatrist. So I think here at one point we have all the support system available,
which actually helps.
Yes, which actually helps.
Actually, which brings me to the last question of this round. Diabetes. So India is becoming a diabetic capital nowadays. Yes, adult diabetes is totally different. Type 2 diabetes. The problem is with the type 1 diabetes. Type 1. I don't know, out of my experience or coincidence, I see the rising trend in type 1 diabetes. Yes. That is something it's very difficult for me as a pediatrician, because me being a parent myself, if any parent comes and suddenly we diagnose diabetes, the moment the child is passing too much of urine and eating a lot but not losing weight. The child is hungry throughout the day but losing weight, passing too much of urine. Then I get a urine test done. The ketones are very high. The sugar level is very high. The diabetes is diagnosed. That's when we refer to the parents.
So when these children come with their parents to us, so sir, mainly the symptoms, the first initial, the main emergency stage, which is called as the acute diabetic ketoacidosis, that has to be taken care of, wherein the acid and the ketone levels in the blood are too high. And then because of these, the children may have symptoms like, very fast breathing, stomach pain, vomiting. And if it goes unrecognized for a while, the children can also land into coma. So this part has to be taken care of first. And so this requires admission in the hospital, and the children will be on IV line and receiving insulin and some fluids. And after this part resolves, once the acid and the ketone levels come down, then starts the actual part of management, which the parents have to start doing at home now. So here, what do we do is so we counsel the parents, we teach them So the main four important pillars of diabetes management we teach them. So first being the blood glucose monitoring. So usually the most commonest method used is like, we prick the finger and the blood glucose is measured. But also nowadays we have the continuous glucose monitoring sensors, which are just like a 2 rupee coin, which you can fix on the arm and it reads the blood glucose, and you can just use your mobile to screen the blood sugar. So the monitoring is very important. These children have to screen their blood sugars at least 4 to 6 times per day. Second important pillar is insulins. And I would say that insulins are the most important part of treatment. Like there is no way that we can stop insulins for these children. And this insulin doses are usually titratable. These are not fixed doses like what we usually see in the prescription charts like 444. It's not like that, because the meal quantity varies as the day passes. The child is sometimes more active physically or sometimes not, so these are titratable doses. Third important part would be the diet again. So there is no special diabetes diet for the children. So it's basically a healthy, balanced, nutritious diet. And I would say that diabetes diets, like, they're very healthy diets, because herein, like, we asked the families to actually balance out, like, the carbohydrates, the proteins and fats, eat a lot of vegetables. So there is no special diet. And actually the entire family can follow the same diet, which is in fact very healthy. And the fourth important pillar would be like physical exercise or activity, because ultimately that does help for the child to be on lesser insulin doses if as the child is like physically active. And also, like, it's important that we counsel the parents that, the diabetes doesn't stop life. We do have so many examples of, celebrities, sports personalities who are like with type
True.
1, and they are like, international swimmers, cricket personalities, and
I think it's
actors.
Wasim Akram who
Yes,
is there.
Wasim
Yeah.
Akram is an example. Yes, yes.
I think who is a diabetic and yet
Yeah.
achieved a lot.
Yes,
And he was turned diabetic even before he started his
yes,
cricket career.
correct.
So that's an
Cricket
interesting
career.
fact.
Yeah. So, so we like always emphasize to the families that, diabetes is just a part of your life, and you need to understand and learn about it, like how you can maintain your blood sugars in the normal range.
See, the concern here is once the diabetes is diagnosed, parents will be in utter state of shock.
Yeah.
What I see in parents is, first of all, is they don't believe it.
Yeah.
They go into non-acceptance, the denial stage. I call it as a
Right.
denial
Yes,
stage.
yes.
It can't be true.
Correct.
So they tend to believe that, my child has eaten a lot of junk food recently or had a lot of sweets recently. I think that's the reason why his sugar level might have gone down. We will just cut down on it. The child will be absolutely fine. This is one aspect. You can answer me for that. I mean, definitely parents require answer from your end. Okay? The second aspect would be the ads, wrong ads which are shown on social media or wherever print media, saying that there's a cure for diabetes. That's a really unfortunate thing, which has got no scientific evidence, saying that you eat or take this jad booty, or so that's the thing. So that is what I have seen. So please give me your viewpoint. We're first getting the parents into your group, giving them the confidence. It's a daily challenge. You require a lot of people, right? Stage of denial and bringing it out. How do you handle it? Give it in a very brief way so that that's understandable. Second thing is the social media posts, which are giving a counterproductive that there is a cure for diabetes, which is really unfortunate thing. There is no cure for diabetes. We know that we can only control it with minimum medication by lifestyle modification. That is something which I wanted your view on. The last aspect which I wanted you to add is the beauty is people are worried about the needles being given. See, first of all, taking a sample itself is so painful for a child. No parent would like to take a sample. Now you have to do a glucose testing. You have to prick it always. Parents, how many times will they prick? That's where the compliance problem comes into the picture. Next problem would be, that is one thing, treatment wise. Second thing would be, continuously monitoring, giving insulin injections, another painful. I think there are easy solutions.
Yes.
Where complaints would be higher. Child did not do anything. Automatically the systems would be there. You can monitor. Because child will be going to school. The mother is worried at house. What might my glucose level would be? She tells to all the school teachers, parents, please look into it. If my child falls giddy or something like that, please look into it. I wanted your viewpoints. What are the recent advances which will make the life both easier for the kid and the parent?
True.
And how do you start it off as a diabetes? Very briefly, how do you take them into the loop? Because it's a part of the team, right? What team is involved in it? And social media posts. Controversial posts, which is it is a cure, immediate cure, you do this, you are fine with it. These are some things which I wanted your
Sure,
views on.
sure. So coming to the first question, sir, that as you rightly said, the parents are in a state of denial. They would be like, oh, like we don't have diabetes, our parents don't have diabetes. How come the child has got diabetes?
True.
So, it takes a while to, get them on board that, that this is diabetes, and to counsel them on the further steps that needs to be taken for the maintaining the blood sugars properly. But with time they do understand, maybe one of the parents is a bit stronger than the other, and then when we see that, and when we see that one person shows confidence, then the other parent also follows him. It's important that the parents are confident, because what we see is usually when the parents are checking the blood sugar of the child, or if they are giving the insulin injection while they are in the hospital, when we are teaching them, if the parent cries or shows anxiety or fear on their face, the child also loses confidence.
True.
So we do teach them, teach the parents that yeah, it's like very natural to
It's
feel
more of
like
an empathy, I think,
it's
empathy.
empathetic approach that that sure, you are feeling huge set of emotions right now, but please show at least little bit of confidence to your child that this is manageable, you know so that's how we start.
I think
How we
I
start.
have wonderful experience
Yeah,
with you, Mounika,
yeah,
because I've referred a few diabetic patients to you.
yeah.
What I have seen is you take that extra amount of time initially to get
Yes.
them into the groove,
Yeah.
make them understand the
Yeah,
disease,
yeah,
make them
yeah.
accept the disease.
Correct.
Now that's what actually plays the role.
Role.
I
Yes,
think
yes.
they're all doing well right now. I
Yeah,
think
yeah.
that's something which every doctor should learn, to have an empathetic approach. It's not
Empathetic
about
approach.
treatment and putting the
Yes,
diagnosis alone. I
yes.
think that is where I think you
Yeah.
have to go that extra yard. Whether it's
Extra yard.
thyroid or whether it's diabetes, anything is a lifelong thing.
Yeah.
So that's where your counseling is for the life now.
Correct.
Understood.
Correct.
Lot of
Correct.
concerns. Parents are concerned about the
Yes.
marriages, about
Yeah,
careers,
yeah.
about everything.
Yeah,
We say,
yeah.
we take it by the day.
Yes.
And being
Yes.
empathetic, I think that's
Correct.
something. Yeah.
Correct.
Coming
To the part that where this excess intake of sweets in the last few days has caused diabetes, that is not the case, because the most common type of diabetes in children is type 1 diabetes, which is an autoimmune mediated diabetes. So it doesn't have anything to do with the lifestyle, right? So we have to again again it's a part of counseling the parents that this is type 1 and it has nothing to do with your excess intake of sweets or lifestyle problem. Now coming to the part lot on the social media or on the print media about that there is a cure for diabetes, and the parents do keep forwarding those articles or messages. Scientifically there is no cure for diabetes as yet.
Yeah.
And that's how. So when the parents want to read more about diabetes, we usually guide them to actually authentic websites like Juvenile Research Diabetes Foundation, JRDF, and so, or the International Diabetes Foundations and Associations, so wherein they have all the ongoing research available,
right,
rather than parents just going haywire and searching on Google, okay, where is the cure in which part. So I would like to highly discourage the parents that do not fall prey to these programs, because this is one practical example I'm telling you. One parent family had they received messages from these random associations who say that you come to us and we'll cure your diabetes. And unfortunately, one family went to them. They tried different kinds of therapy, stopped insulin, and they landed back to us with complication of diabetic ketoacidosis. So I highly discourage parents to fall prey to all these programs, right? And coming to the point now, so the children mainly, where is the anxiety? So anxiety for the children is when they have to prick their fingers for checking the blood sugars and also to take the insulin injections. So wherein the children get little scared of needles, there is fear of needles.
And even how much dose to give.
Yeah, that's a confusion. How much dose to give? And now, in the midnight, there will be chances of low sugar. So parents sometimes, they just lose their sleep over months. They come back and say that we have not slept for months together in the nights, because they're worried if their child would drop in the blood sugars. So we do have technology helping us these days. So instead of checking the finger prick blood sugars, we have this continuous glucose monitoring sensors, which do a decent job. They keep on monitoring the blood sugars, but you have to scan them. And also we have the cloud now, wherein the information or the data can be relayed to the parents, can be relayed to the doctor as well.
Oh, excellent.
Yeah. And we are also now going to have some real-time alert systems also in one of the company, which is going to get that in few months, wherein like when the blood sugar is going to trend low, the parents will receive the alarm.
Alerts.
Oh,
that's fine.
Alerts and alarms. So that is going to be really nice once it comes. And regarding giving insulin injections, so insulin pumps are available. So insulin pump is nothing but a reservoir of insulin which is attached through a tubing to the tummy, and it keeps on delivering the insulin continuously. So if the children are afraid of the pricks, the parents can probably like switch to the insulin pumps. But then again, like some challenges in India right now are the cost of the insulin pump, but it would be like wonderful to have, because that is like almost mimicking the natural secretion of insulin.